Okay. Good afternoon, everybody. We welcome you all to the last session of the nursing e-module on preterm care. And we are lucky to have all the faculty of the week with us. It has been a lovely interaction with all the questions and answers and very practical and very relevant questions asked. And the faculty has been really active this week. We welcome all the faculty members, Dr. Raman, Dr. Prashant, Dr. Natasha, Dr. Anita, Dr. Surinder Bisht, our dear sister Hina, and of course, Durari sir is with us today. We will be taking your questions live on YouTube chat. Please post your questions there. We will begin with a short presentation summarizing the learnings from the week, and all the presenters will be presenting around 4 to 5 slides and just giving the key messages from their topics. We'll begin with Dr. Raman, who will just tell us why actually ROP happens. The topic was follow-up and ROP screening. So we'll begin with why does actually ROP happen, and then we'll move on to the strategies to prevent it, and then how to follow up these babies. Dr. Raman, I am beginning to share the slides now.
Fine. Thank you. So, very good afternoon to everyone. Am I audible?
Yes.
So, a very good afternoon and a very happy new year to everyone. Hope this year becomes a great year for all of you. So, I will start with my topic. First thing, I would like to thank our mentor, Dr. Ashok Durari, for including us in this wonderful course, and Dr. Pratima, who has been leading from the front. So the topic for this module was ROP prevention and follow-up, and the participants have been very active during the past week, and very healthy discussion is going on. So I will start with the first slide. So the basic essence why this module was included in the preterm care, because ROP is a very important common cause of preventable blindness in infancy, and all the NICU care staff should know about retinopathy of prematurity, and it is why I am saying that it is preventable cause of blindness, because a timely screening and treatment can prevent blindness and visual confusion. And the reported incidence of ROP in various studies have been 20 to 30% of all screened infants, and you must be knowing that with increasing awareness and education status in the parents, and there has been rapid rise of medical negligence cases against doctors in ROP. So you have to be very careful, and ROP screening is mandatory in all the eligible infants where it has to be done. So the definition is it is a condition characterized by development of new abnormal blood vessels in the eyes of the preterm infant. So this the abnormal blood vessels, what do I mean by this is that these blood vessels are not normal. They are leaky, and they are fragile, and they leak a lot of exudate in the retina, which leads to the formation of a scar tissue, and ultimately this scar tissue causes traction to the retina and retinal detachment. The first report was done in 1942, where the infant was subjected to oxygen-rich environment, and from that we get the association of oxygen-rich environment for the pathogenesis of ROP. So this is a diagram which shows the pathogenesis of ROP. So in utero, the normal vessel growth occurs because there is a hypoxic environment in the utero. So this hypoxic environment is conducive for the normal vessel growth in the baby. There are good amount of hormones like insulin-like growth factor, we have vascular endothelial growth factor, which is very important in the pathogenesis of ROP, which is there in utero. But when the baby is born prematurely, this growth factors, they decrease. And when, so phase 1 ROP which develop is because of hypoxia, so in the retina. So what happens is, when the baby is born in the oxygen rich environment, so everybody in the after the delivery of the baby starts oxygen. So this oxygen, what it does is that it causes decrease in the levels of VEGF, IGF-1 and erythropoietin. So this causes the vessel growth, the normal vessel growth of the retina to stop. So this is comprising the phase 1 of the ROP, where the normal vessel growth is stopped. But after some weeks, so after maybe 30 to 32 weeks of postmenstrual age, what happens is, because of increasing metabolism in the avascular retina and hypoxia, there is sudden rise in this growth factors, like increased vascular endothelial growth factor. And this increased sudden rise of this vascular endothelial growth factor causes the formation of retinal neovascularization. But you should remember that this neovascularization which is happening now is not normal. This is abnormal. The vessels are leaky, and these leaky and fragile vessels causes the formation of scar in the retina, and ultimately leading to the retinal detachment. That is why in the phase 2 of the ROP, we do laser therapy to decrease this stimulatory effect of vascular endothelial growth factor. Next slide, please. So this is the slide which is summarizing the same thing which I have reported. So there is so the risk factors for ROP is, it is basically a multifactorial disorder, and the incidence is more in decreasing gestational age. But in our country, we are getting more of a larger babies with very severe ROP. So that is why we have to improve our quality of care. So that is why this module was conceived, to decrease the risk of to decrease the incidence of ROP by improving the quality of care. The major risk factors are, again, the low birth weight and prematurity, and the injudicious use of oxygen. So oxygen has to be used as a drug, and it has to be used judiciously. And repeated blood transfusion is also a very big risk factor. And in our scenario, sepsis and IUGR and poor nutrition is also a risk factor for ROP. So these are for the risk factors. Dr. Prashant will be taking the prevention of ROP in the next presentation. Thank you.
Thank you, Dr. Aman. I think we understood that hypoxia and hyperoxia both can contribute to development of ROP, and we need to be really careful by providing quality care, because each step is important and crucial, and it may lead to life-threatening, sight-threatening, lifelong morbidity in the newborn. Thank you. Dr. Prashant, I would like to invite you now for enlightening us for preventive steps, basic preventive steps which can be followed in the delivery room as well as in the NICU. I'll be just sharing the slides.
Sure. Amanpreet sir has actually given a good introduction about how ROP starts, and and we also saw various factors which insights for the development, incidence and development of ROP. So I'm going to take you through 4 to 5 slides. I'm going to tell about some practical aspects about how to prevent ROP. Okay, we know that one of the most important factor for retinopathy of prematurity is prematurity and low birth weight. Correct? So unfortunately, not much can be done to probably prevent the preterm birth. But what we certainly can do is we can definitely improve our preterm outcomes. If you look at the guidance which the WHO has brought out, so if we give good preterm outcomes, we also can prevent ROP. Because ROP, as we know that it's multifactorial, there is not even no one single intervention which can prevent it altogether. It's the comprehensive management of a preterm to get good outcomes which can prevent ROP in this baby. For example, provision of antenatal steroids, antibiotics for chorioamnitis or PPRM for the mothers, a good thermal care in the delivery room as well as in NICU and throughout the course of prematurity and later on. Judicious administration of ventilatory support like usage of CPAP, administration of surfactant at appropriate time, and the other most important thing, we know that optimal oxygen therapy. These are some of the guidelines which WHO has given us, and each one of us should follow to improve preterm outcomes. Thereby, these things can also translate to decrease in the ROP. So let's look at what we can do in the delivery room management. We all know multiple blood transfusion, because the blood we transfuse to babies contains adult hemoglobin. We probably need to avoid it as much as possible. When it's necessary, we give it, but when it is not necessary, if there are any interventions where we can reduce the blood transfusion, as we saw in one of the models, we can do that. The most important thing which we can do is delayed cord clamping in the delivery room and timely resuscitation, because we know that if the baby gets, if the APGAR scores are less, that can translate to ROP. Temperature regulation in the delivery room, that is, the babies definitely less than 32 weeks definitely receive cling wrap care, which has been mentioned in the neonatal resuscitation program. Usage of delivery room CPAP for respiratory distress in preterms, as well as usage of TPIS resuscitator for positive pressure ventilation for preterm resuscitation, and also the oxygen targeting in the delivery room. We know that there is different set of guidelines for oxygen targeting based on the minutes after birth. So we need to be looking at oxygen targeting every minute and judicious use of oxygen in the delivery room by usage of blenders. And since this baby might require, most of these babies might require NICU care, safe transport from delivery room and delivery room to the NICU should be ensured. So these are some of the things which we can do in delivery room. So what we can do after that in management, for you to understand and remember. So we have this mnemonic which actually came out in seminars in perinatology 2019, which helps us remember the management points by acronym points, right? So P stands for pain control. We know that with pain there's a lot of oxygen, saturation fluctuations. We need to avoid that. We need to have pain control. O stand for optimal oxygen management. I stand for infection control. N is nutrition. T is temperature control. S for supportive development care. So some of the things which I would want to mention under these things, can we move on to the next slide, ma'am? So for pain control, we need to reduce unnecessary and painful procedures. We know that procedures are inevitable in our babies, but we need to reduce unnecessary painful procedures. Anticipate pain and prevent by swaddling or usage of oral breast milk or anything. Optimal oxygen management, very important. These preterm infants on supplementary oxygen should be monitored by pulse oximeters, and we need to display an agreed saturation target, and we need to ensure that it is stuck in ensure that it has been monitored, and we titrate oxygen based on our oxygen saturation targets of 91 to 95%. Again, an infection control, one of the most important aspects in NICU care is some of them are hand hygiene protocols, which apply to all NICUs, protocol based antibiotic stewardship. So with this we can control infection, thereby ROP, prevent ROP. Other most important thing, we know that the babies require adequate nutrition support. The preferred choice and which we need to get is the mother's breast milk feeding as early as possible and get on to full feeds as soon as possible. You need to provide additional calories and proteins if the weight gain is not adequate, because we know that inadequate weight gain will lead to ROP. So again, reiterating the importance of temperature control, we need to prevent hypothermia as well as hyperthermia in NICUs. And the other most important thing is, the thing is to prevent the drafts and overheating also in the temperature. So we need to provide all our babies supportive and developmental care. We know that kangaroo mother care is the answer, which can answer which can address most of the problems in premature babies. We need to facilitate kangaroo care in NICUs as well as support the parents throughout the stay in NICU. So these are the points which we need to ensure, and we need to have it as a must in NICU to prevent ROP. Other aspects we also have discussed over a few days now, that the importance of caffeine, because caffeine would prevent the apnea of prematurity, thereby prevent fluctuations in saturation, extrapolates to decrease in the ROP later on. We need to decrease invasive ventilation days, use CPAP as much as possible, and get the baby out of ventilator as soon as possible, prevent ventilator-associated pneumonias, prevention of other morbidities. We know that most of the problems are interlinked in our babies. Like, we need to ensure that the other morbidities which the babies go through, like IVH, NEC, BPD, all these things have to be prevented to ensure that the babies don't get ROP. So we need to have restriction transfusion guidelines in our NICU. We need to also look at maintaining the metabolic homeostasis. Like, for example, we need to have normal glucose levels, prevent hyperglycemia, prevent hypoglycemia, get your electrolytes in the normal range, and make sure they get all micronutrients possible and maintain homeostasis. Again, the most important thing we're going to talk about in the subsequent slides is the screening protocol, which should be in place in every NICU which caters to preterm babies, and ensure that it is followed. So these are the aspects we need to be mindful of to prevent ROP. Thank you, ma'am. That's all from me.
Thank you, Dr. Prashant. I think there were very practical aspects which were covered, and throughout the week also we stressed on the delivery room management. So we nurses and doctors always work as team, and nurses are the backbone. We all agree with this. Now let us see and let us hear from Ms. Hina. What role does the nursing staff and in fact the residents have in prevention of ROP? Hina? Hina is there?
Am I audible, ma'am?
Yes, Hina, you are audible. Please continue.
Good morning to everyone. Now we will discuss about the role of nurse in prevention of ROP. Just 1 second. As we know, the neonatal nurses are the pillar of NICU, and their knowledge and clinical skills are essential in provide best practices in improving the quality care and thereby reducing the ROP. And mainly, if we focus on the role of a nurse, there are basically 4 main roles. The first one is specialist knowledge in clinical management, their leadership and mentoring, and how they are doing the clinical advocacy and their counseling. These are the 4 main aspects. The first one is specialist knowledge in clinical management. First of all, as Dr. Raman and Dr. Prashant has already covered how ROP occurs, what are the different risk factors and how to prevent them. So we nurses, we should be aware of all the risk factors which are known to be associated with ROP, like injudicious use of oxygen, poor weight gain, infections, and repeated blood transfusion. So we should have a team system, a core team, which can implement the good practices like target oxygen saturation by setting alarms of the monitors so that there should be no hypoxia as well as hyperoxia. And we should have a prompt response to these alarms. Encourage breastfeeding and encourage the mothers to express their milk, hand hygiene, how to wash hands as soon as the delivery occurs and the baby is inside the NICU. We should educate the caregiver, also the mothers, how they should Shall I continue, ma'am?
Yes, please. Yes, Hina, continue. I think Dr. Anita got unmuted.
Okay. asepsis to reduce infection, support for nutrition to achieve good weight gain. We have to support them so that baby can gain good weight. Now, the second one is clinical advocacy. We have to be the best advocate for providing the best practices in our NICU. Some of them include kangaroo mother care, thermal care, when the mothers or their father or the caregiver enters, how to provide KMC, what are the prerequisites of KMC, what are the benefits, and how they have to cover their babies, and to minimize the heat loss mechanism, the things which can cause heat loss leading to the poor weight gain. We have to control that part also. Infection prevention, and also promoting breastfeeding. Advocating for the adjustment of the environment also, like minimal handling by providing cluster care, reducing stimulation like noise and light, and developmental care are the core component of our nursing. And the third one is leadership and mentoring. Leadership from within the nursing profession on based on the policy on educational opportunities, as well as the competency based training program. Like senior nurses, they can train their junior nurses, they can take part in educational opportunities, and the training program has to be there, and it need to be updated time by time. Experienced nurse can coach the young nurses to improve the quality care in NICU. And the fourth one is the counseling. The nurses should play an important role in counseling the parents regarding breast milk and kangaroo care. They also provide emotional support, and they should motivate the parents for the developmental care, how to maintain the adherence to ROP screening program, follow-up. Using innovative strategies such as ROP appointment and follow-up card, or using some applications can ensure timely management of ROP. And the take-home message is we have to identify the newborn at a risk of ROP at the admission to NICU. What are the risk factors, and which babies are potentially likely to be developed ROP? Note the expected screening date and time in the case file. We have to encourage the communication for improve the coverage of antenatal steroid. Restrict oxygen use in NICU, maintaining the saturation of all babies at a target level at between 90 to 95, and promptly responding to the alarms. Restrict usage of duration of antibiotic. We have to see our chart, which is the day of antibiotic, 2 days, day 6 or day 7. In case if there is any issue, we have to inform our pediatrician. In intravenous fluid, parental nutrition, and CPAP. Encourage mother of preterm babies to use kangaroo mother care, continue with breastfeeding and aggressive enteral nutrition. And for development supportive care, how can they reduce the pain, and how they have provided swaddling, facilitated tucking, how they can talk to the babies. Like this kind of supportive care also can help the babies. Thank you.
Thank you so much, Hina, for stressing on the ground level implementations which can be done by the residents as well as the nursing staff.
Thank you.
And last week we discussed that who should be screened actually. So as per the Government of India guidelines, we need to actually screen all the babies less than 35 weeks or less than 2 kgs, plus those babies who had some torment course in the NICU. So now once we know that whom to screen, how to prepare for screening, and what all things to be taken care of while preparing the newborns inside NICU or who come for ROP screening, how to prepare them, Dr. Anita will be sharing with us. I welcome you, Dr. Anita.
Dear advisor, today this becomes an important role for nurses. How do you prepare people for ROP screening, our babies for ROP screening? Can I have the next slide? So I've just put it in a very small checklist, because when a checklist, we make sure that all the things that are done in our unit, and I've just put it in an easy manner such that we can just recollect it subcortically too. So always we look out for an area where we have to do the screening. So it should be, if we have discharged the baby before the ROP screening, it should be accessible to them so that we can ask them to come to a designated area of the SNCU for after discharge for the ROP screening. That has to be informed to them previously. And of course, it has to be sepsis free, and we have to take care of the hygiene of the babies there too. Then the babies, D4 babies, whom are we going to screen? These are important numbers that we have to remember. Babies less than 35 weeks and less than 2 kg will come under the screening criteria. And anybody above this with risk factors, that so many that we have learned all these days, prolonged oxygen therapy, mechanical ventilation, sepsis, blood transfusion, so on and so forth, they will also come under the screening criteria. When it has to be done, it has to be done at the 4th week if the baby is born more than 30 weeks. And if the gestational age at birth is going to be less than 30 weeks, screening before 3rd week is mandatory. Like 2 to 3 weeks postnatal age, they have to be screened. Consultant, we have to look for an ophthalmologist who is trained in ROP screening. That will be very mandatory because the findings may not really coincide with somebody who is not trained in the field. Then D for documents. An informed consent form from the parents has to be taken. We have to keep a form which is ready to document the ROP findings at each setting or each screening. And we should have a follow-up plan schedule based on the findings that we observe in the ROP. Next. So this is getting our equipments ready. So I've just put it into a 6 headings. We need the tools, just as we saw during our discussion. It is an indirect ophthalmoscopy with the 2 lenses required to look out for the ROP. Our eyelid retractors and scleral depressors, all which are sterilized, and we have to keep them in adequate numbers depending on the number of babies each SNCU has to screen. Maximum around to the tune of 15 to 20 per unit. Drops. What are the drops that we are going to use? Tropicamide, which is the main dilator. The concentration that we need is around 0.4 to 0.5. Available drops are around 1%, so they have to be diluted half, 1:1 ratio, so that it has to be brought down by concentration. Phenylephrine is what we require is around 2.5%, and it is available as 5%, which has to be diluted to this particular 2.5 concentration. For anesthetic purpose, we require paracrine drops and artificial tears during the procedures to make it less painful, and antibiotics if need be. Diluents, we use distilled water. We do not use normal saline because that becomes an irritant to the eyes since it's sodium there. We require 5 and 10 ml syringes so that we dilute the drops. For asepsis, we need to wash our hands with soap and water. We have a pair of sterile gloves for 2 people, and the hand sanitizer to use in between the examinations for each, in between the babies. For pain control, we need to keep ready 25% dextrose or a gauze dipped in express breast milk, swaddling, and KMC. For monitoring purpose, we need a pulse oximeter, and we need to have a dedicated personnel for this, but during the procedure to monitor the vitals. F, definitely, this is very, very important why people do forget. That is why I made a single slide for this one. Keeping the baby NPO for 2 hours prior procedure. This is very important. Next. So, and there you go. So A, B, C, D, E, F, and go are the entire procedure. Of course, the nurses are in a position to explain to the parents once more that what is the procedure that they are going to do. Please reassure them it is going to be less painful, less stressful. They will make it as comfortable as to the baby. So the parent should not be in an anxious state. So explain to them once more and keep the diluted strength of the drops. Instill the drops in the lower palpebral conjunctiva. Ensure dilatation. The pupils will start dilating 30 minutes after almost twice installation of your tropicamide, and they will remain dilated for another 30 to 45 minutes. So during the procedure, we can have a pain control with a anti-anesthetic paracrine drops, etc. And a pulse oximeter to look out on the vitals, because bradypnea, apnea, and bradycardia are common during the procedure. And it's mandatory that a personnel records the findings of the ROP in the ROP chart. Handover the recorded documents should be handed over to the concerned neonatologist and to the parents. We need to plan a follow-up plans and a schedule for it. So with that, we finished how do we go about the procedure in an ABCD format. Thank you, Pratima.
Thank you, Dr. Anita, for an excellent summarization of the preparation. And once we have prepared and done the screening, how to actually, what all to look for? There are small things after ROP screening. There are some complaints which the parents may do. I mean, for feed regurgitation or something like that. And what all care should be taken post screening in the NICU. So that Dr. Natasha will be covering. I am just sharing your slides, Dr. Natasha. Welcome, Dr. Natasha. Over to you, please.
Hi, good afternoon, everyone. So basically in this time, a very quick and crisp, I'll discuss as a nursing role in what you should do once the ROP screening is over. So ROP screening is over, there might be something where you have detected an early ROP. So the very first point is, how do you follow up if there is an early ROP? If the baby has been detected, we just have to make sure that there is a correction of anemia, take a strict precautions for the oxygen supplementation, prevent both hypoxia and hyperoxia, and keep a track of follow-up schedule so that the next screening visit is not missed. So all these 3 points are very, very important, because the first 2 points very well suggest us that we should be able to prevent the further progression of ROP. No matter we have detected early ROP, but there is a good chance that we can prevent the progression of ROP. So in case if we have found out that there is a severe ROP during the ROP screening, so again, very important points here that we really need to make sure that if it needs an urgent laser right away, so we should arrange for the good hemodynamic monitoring and asepsis during the procedure. We should make sure a senior nursing staff and a doctor are available around the train, along with the trained ophthalmologist during the procedure, because there might be sudden hemodynamic instability because it's a long procedure. It takes almost 2 to 3 hours. If the baby is already unstable, might need even intubation. So it's very, very important as a nursing staff that whenever we detect a severe ROP, all those things should be ready bedside. So for the severe ROP, if at all we need an urgent surgery. Next slide, please. Coming to the feeding and other post ROP screening care, I would say routine care is usually not affected in a routine ROP screening. Like we do in our unit every Thursday in the morning at around 8 o'clock. We do a routine for routine feeding, routine procedures and everything post ROP. So if there are no major concerns, there are no contraindication of any ongoing treatment post ROP, so we don't need to be worried about any further thing. But some units might develop transient feed intolerance, as Dr. Anita has also mentioned, post procedure, as the eye drops which I use are anticholinergic. So we can keep a close watch, and feeding we don't need in our unit, we don't withhold, but yes, in case if we notice any kind of feed intolerance, we might need to hold the feeding for a while. Coming to monitoring, as a nursing staff, again, it is very, very important for you. Once the ROP screening is over, we have to watch the babies for apneas or bradycardias, which might be again possible because ROP screening stimulates the oculocardiac reflex, which might lead to sudden apneas and bradycardias, which might be again a very transient thing to happen. So that needs a close monitoring for all the babies who have gone through ROP. If the neonate is unstable prior to the ROP screening, again the clinical and hemodynamic monitoring need to be escalated because it can further worsen sometimes. So if the baby is sick but ROP screening has been done, we have to be even more cautious. And there might be definitely a need of pain relief even after the ROP screening. There might be some neonates who might be very, very sensitive and need further pain relief, as other previous consultants have already mentioned the pain relief, so I'm not going into detail of that. A very important and the last point which I would like to reinsure is parental counseling. Although we know that the ophthalmologist as well as a neonatologist who is involved in the care of the baby would be definitely involved in the parental counseling, but I would say as a nurse, what you can do, the doctors cannot do, because you are mostly bedside and mothers and everybody would be more conversant with you. So make sure that you also involve and reassure the parents about the ROP counseling. They should also be aware, if it's on outpatient basis, they should be aware about the follow-up schedule. If they are on inpatient basis, anyways, you would be noting it down how to do the further follow-up and when it is. And if the neonate is detected to have a severe ROP, as I told you, along with the senior doctors and ophthalmologists, nursing role is very, very important in counseling the parents. The date, time, and procedure plan should go into the nursing communication book for the proper handover, so that the next follow-up visit is not missed. So that's all from my side.
Thank you, Dr. Natasha. Thank you very much. Once the screening procedure is completed and we have followed up in the immediate post-screening period, we also need to know that along with the ROP visit, there are other things which we need to monitor in the baby. So, what are the other things which we need to follow up and which we need to actually note it down when the baby is posted for ROP, as well as when he comes for follow-up as an OPD patient? So, Dr. Madhvi, I invite you to please elaborate on the principles of follow-up of other morbidities, comorbidities, as well as other parameters which should be done in. Dr. Madhvi? Dr. Madhvi, can you hear us? Okay, I'll just move the slides. I think she's not able to hear us. So why follow-up is important? The goals of a preterm care and follow-up along with ROP follow-up is to have an intact survival. So not only saving the babies, but we have to save the babies without disability and ensure a healthy life. And so we need to do a developmental assessment and screen the babies for neurodisabilities so that they can be timely referred for physiotherapy, for vision or hearing intervention if at all it is required. So at the time of discharge only, the readiness should be done for the follow-up visit, because building a rapport at the time of discharge is very important. The baby should be, the parents rather should be counseled to keep the baby warm, and they should be explained about what is the actual weight gain which is to be done, what are the feeding methods which should be done if the baby is not on direct breastfeeding, and any significant morbidity which may require any home medications, that should also be taught. Parental education and readiness is to be ensured, and they should be actually LPAC should be practiced, and their knowledge should be checked whether they are actually understanding what we have counseled them for. And a comprehensive care of a preterm baby not only includes eye checkup, which we are discussing right now and focused on that, but we also should have a dedicated staff, fixed days every week, discharge planning and a checklist, follow-up checklist for the medical care. What does the medical care means? That if the baby had some chronic illness like chronic lung disease, BPD, if the baby had some meningitis, any sepsis, then how to follow them up? What are the things which should be looked for? Hearing assessment, ultrasound, head ultrasound, and a proper neurodevelopmental assessment, which can include a screening test as well as a confirmatory developmental assessment if needed. So all these things should be a multidisciplinary and a multi-component visit. It should not be that ROP visit ho gaya, then we should leave it here. So we should look the baby as a wholesome and in a entire in an entity. So not miss the growth and development part. So discharge summary checklist, each unit can have its own customized checklist, but these are the broad guidelines which we can give you. Gestational age, birth weight, risk factors for neurodevelopmental, if any, weight and head circumference tracking on the preterm growth chart, nutrition advices, supplements, and kangaroo mother care. Immunization advice is very important, either at the center in which the delivery has taken place or nearby. But immunization should be explained. Screening test, which we already discussed, that ROP, hearing, and ultrasound head if needed. parents should be explained clearly about the dates of screening, the need for screening, otherwise they won't turn up. So you should explain the need, why it is needed, why a hearing assessment is needed, why a head ultrasound is needed, why a developmental assessment needs to be done, and the parents need to bring the baby to the follow-up clinic. Danger signs explanation, and when to report to emergency, and what are the emergency phone numbers, and the next date. Actually, not telling them randomly that you should come after 2 weeks or 3 weeks. Give them a date and a time and a place to follow up. I think that summarizes the multi-component follow-up which should be done along with the ROP visit. Okay, inside the NICU also, as we have explained you, counseling and talking to the parents. And then when a patient comes as an OPD basis, then also you should explain them. Okay, so that's about it. Dr. Madhvi, can you hear us? No. Would you like to add anything? ROP, apart from the clinical aspects, one aspect of ROP or in fact any clinical care is the medical legal aspects. It is scary at times, but we need to be aware what can be the medical legal aspects of ROP, and I invite Dr. Surinder Bisht, who is an experienced pediatrician as well as practicing neonatologist. So Dr. Surinder, please take over.
Thank you, Dr. Professor Devrari, Pratima, and Amanpreet for actually making it such a wonderful. I was wondering, it is on the fag end, the last, but we could do it. Please give you for the next slide. I think this has been explained by Amanpreet and all, Prashant also in earlier slides, that we have a high rate of prematurity in India. And now with this survival has certainly increased. This is not 93%, but in some centers, the survival of babies between 28 to 32 weeks actually have increased to a great. That is why we are able to see more of ROPs. And as Prashant told, there is a problem of use of oxygen. People don't actually restrict oxygen use in there, and there is a lack of sensitization of care providers. And we have around 1,000 and more SNCUs where we are in a hurry to save babies and we want to do some extra for those babies. Probably we are giving more oxygen, and there is a lack of uniform ROP screening protocols implementation. Now that Government of India has already made one, so there is a protocol, but it is not being implemented uniformly. And as Amanpreet said, we in India have a heavier and more mature infants developing severe blinding, stage 5. Next. So I'll just go through a few of the cases which have occurred. So this is a case in which, and this happened in Dayanand Medical College. Now that it's a case which is, you Google it, you will find it. The first case, the child was born at 31 weeks, gestation with LSCS. The birth weight was around 1.34 kg, and the baby was kept in nursery, given oxygen, discharged at 38 days. Good things. The baby actually went back home, but at 8 days chronological age, baby was examined by ophthalmologist, which was, but for ROP which was not seen. Next. No ROP screening was done at 4 to 6 weeks as recommended. No mention was being made in discharge summary of the child whether ROP screening was done, nor was it mentioned that ROP screening should be done every 2 weeks. Next. On follow-up, the child was advised to be taken to IOPD, but the relatives did not go to the IOPD till 1.5 months later, when it was found that she had stage 5 ROP. So the court actually took some observation, and the court held that this referral done at 6 weeks does not absolve. So the doctors of negligence, as even on this referral, it was mentioned whether ROP screening had been performed. It was not mentioned clearly whether ROP screening was done or not. And it was held that it was not the case where the patient was negligent in obeying, because the patient was not being told. And the court felt that the doctor did not inform the complainants about the seriousness. So that seriousness was important. Yeah, aap aankh dikha lena, you just go and get your eyes checked, was the only thing which was done. And the family was not told about the seriousness, the gravity of blindness as in complication of ROP. This was not told. And yes, The judgment said that when the problem have been outlined, that such a premature, the appellant actually said we had the premature babies have so many issues and so many things. We got his this thing HMD corrected. We got his so many things corrected. This is something which can be missed. So the judgment said that when the problems have been outlined that a premature infant could suffer from one or the other problem, it becomes the duty of the doctor to take care of each and every problem which the infant is likely to suffer. So here we have to take care of. This is another interesting case, and here it is interesting that it was against the state of Tamil Nadu, V. Krishna Kumar versus state of Tamil Nadu in 2015, and it has the highest compensation also. The baby delivered in a government hospital at 29 weeks, and the doctor discharged, and they did home visits in 15 weeks. Even after 15 weeks, the baby was being followed, and the main defense which the respondents and with the government doctors gave was that the baby did not have this when the baby was born, and the baby developed it later. The court felt that it was the hospital to give a clear indication as to what was to be done regarding all possible dangers. Just saying we have informed you about the danger signs or alarm signs is not good enough, and the total compensation is the highest of 1.86 crore, equivalent to $0.6 million was awarded. And the other case here also, yeah. So here is the doctors in 28 to 30 weeks gestation baby. The doctors the baby was born and then shifted to other hospital. At 3 months chronological age, baby was noted for excessive crying, and she was again examined by pediatricians. And then never were the patients advised about ophthalmological examination to rule out ROP. And yes, the compensation was awarded for that. Here it is a difficult case. In fact, the doctor did a lot of things in this baby. Actually, baby was 32 weeks, 1500 grams, surfactant therapy, blood component, was kept on mechanical ventilation. The ophthalmological examination was done at 4 weeks chronological age for ROP, but did not write down in medical records. Maybe they said that they did it, but when the court felt that the ROP screening protocol was not mentioned. In fact, the doctors and the nurses' notes were not clear, which instruments have been done, how they were used, what was the procedure was, and everything was to be mentioned. So the court thought that should have performed retinal examination with binocular indirect ophthalmoscope, not a torch or something like that, on dilatation of people with scleral depression to ascertain. So this is the court observed that it should have been done the way Dr. Anita was telling. The court felt, so in the first, the 4 cases actually said the court felt the doctor did not inform the complainants about the seriousness of the disease. In case 2, it was all the possible dangers were not told to the family, and in case 3, never were the parents advised about ophthalmological examination to rule out ROP. And case 4, the doctors did perform ROP, but did it as per the screening protocol, and they did not write it. So next slide. So where does the buck stops? The buck stops with the pediatrician and ophthalmologists are supposed to adhere to the latest ROP guidelines, from which we have the Ministry of Health and Family Welfare guidelines. The ophthalmologist has an important role and responsibility, but since he comes to NICU as a guest only, and he doesn't know about all the babies who need to be screened, somebody needs to tell him. So the onus and the responsibility lies on the neonatologist to screen babies, and there needs to be multiple individuals like nurses, doctors, physicians, non-physician caregivers, some social workers. They all need to be a part of that, and apart from training and comfort level. This is a problem. Many ophthalmologists and retina specialists do not want to do this because of risk of litigation. I have faced it myself in my place. They were not ready to do it. So possible remedies could be using a digital photographic retinal images, a RETCam or Indian version of a RETCam that can capture and that can show that what was happening. Communication with parents by members of the care team is very important, as is the documentation of those communications. So this is something which the court had observed, that it was not properly documented, and the parents should be aware of ROP examination, and they should be informed if the child has ROP with subsequent updates on ROP progression. Now you need to come every 1 week or 3 days. Sometimes we ask them in AP ROP also. A documentation of such conversations with parents in the nurse or physician notes is highly recommended. Thank you.
Thank you so much, Dr. Surinder, for actually sharing the examples, real life examples which have happened. I would request Dr. Derari sir to please take up the questions with faculty. I'll be posting the questions, sir.
But we don't have any live questions at this point. So in any case, I think this has been a wonderful presentation by all the faculty members. And, everyone has shared that ROP is a preventable disease. And the other thing which is very important is we need to be taking care that we are saving ourselves as a medical professional from getting into litigation. We also must know that preterm babies are likely to have some complications which are beyond our hands. They are part of medical treatment which happens. But here comes, how do you communicate with the family? How do you explain to the family? And how do you follow up with the family? How do you make that connection? And if you are asking someone to come for follow-up, where do they come, at what time, then whether you are available at that point of time, or you have a system which is in place at that point of time. And then keeping all your records complete. Recording is very important, whether you are recording the pulse oximetry or not, if you have done some intervention, or if your child has some problem, whether that is documented or not. So if you keep your records complete, you communicate well. We know some complications will occur in newborn babies who are preterm or who are sick. I'm very sure most of the time it does not get into court or litigation does not happen. But if we don't follow all these things, we don't communicate, we don't talk, we don't give time for proper follow-up of the patient, don't document the things on the discharge summary. Even if you have told them that they have to come for a follow-up after 2 weeks, if you are discharging early, you must write down that on the discharge that you have talked to them, make sure they understand that, and you document that. So we know ROP is a problem which will occur in preterm babies, and as you listened, it occurs in babies who are a little bit bigger also. The entire module which has been shared with all of you, all the nurses, and what the faculty has done in the last 10 weeks, all the 9 modules which are preceding, they were all targeted to that you want to prevent this complication of ROP in preterm babies, and you wanted to have a better outcome so that quality care can be given to newborn babies who are preterm, who are sick. And it is building your knowledge, it is showing you some videos to build up your skills also, but you have to create your own systems at the place where you are working. And again, it is a teamwork, as a lot of people have said. You have to work with your senior doctors, you have to work with your resident doctors, if it is a medical college or an institution, and then take everyone together, make SOPs and protocol and follow them. And then you have to work with the obstetrician, because antenatal corticosteroids, as Prashant said, is so important. Labor delivery room care is very important. First 1 hour is very important. Surfactant use is important. Early CPAP is important. We know all that. And we need to prevent infection also. So appropriate use of antibiotics, especially for prolonged premature rupture of membrane, has to be there. So sepsis has to be treated. You also learned about that judicious blood transfusion should be used. Unnecessarily blood should not be. So I think everything boils down to prevention strategy while you are talking of a care for a preterm baby. And having all that capsule which is given over last 10 weeks to all of you, I think it is a great package, and we will learn from the feedback which we'll get from the faculty and the students and try to improve the next time. And I'm very sure it is a great learning experience, at least for me. I don't know about the faculty members. It's a great learning experience in the last 10 weeks, because I have been peeping in and each week trying to listen to all the faculty members, how this good experience this has been. So I would request Pratima now to take a follow-up on the Google Sheet once again from all the participants and the faculty member, so that we are able to improve the next time while we do another course for more nurses. This time it was 4,623 or 10 in number, and maybe next time it will be, all these girls will bring another 2 or 3 of their friends. So it will be 8,000 or 9,000 nurses who will join for the next course whenever we do it. Over to you, Pratima.
Thank you so much, all the faculty members, and the structured module which was there, sir. I think it was made after the feedback from around 130 experts, and it has been really a good learning experience for us. Answering the queries from the participants has been, in fact, enlightening for us, sir. I'm sure the faculty must be agreeing with me right now. Thank you. Thank you so much.
I am so happy to see today the chat box is totally neat and so you have to collate the result, find out who are the best three staff nurses. As promised, we are going to give award to all first three, and then the certificate to the nurses based on whatever minimum standards you have kept for their quiz, their participation, interaction, for the certificates, which will be online e-certificate for them.
Yes, sir.
We should also remember that learning all these courses is not that you are going to become a doctor and then start claiming that you are a neonatologist who is a preterm sick newborn baby doctor and you have this certificate. No, just getting your skills, and it is telling you to create a system and work with people and add to knowledge. And if we are doing something different, you should come on track and try to do the best evidence-based practices for management of sick preterm babies. Okay.
Yes, sir.
So thank you once again, everyone. Aman, Prashant, Natasha, Anita, Surinder Bisht, Hina, and Madhvi. We were not able to see her. And I'm so happy that we have people, faculty members from entire country, from South India, then Hyderabad, then we have people from Vizag, then Ludhiana, then we have Bangalore, New Delhi, and UCM also. So we have people who are each week from